So pelvic floor anatomy, reasons why some of these things are important for us to think about. Layer 1 and layer 2 are superficial layers of the pelvic floor musculature, come off of the ischial tuberosity and to the ischial rami of the perineal body. Layer 3, or the levator ani, attach into the pubic bone, pubic symphysis, ischial spine, coccyx, sacrum, fascia of the obturator internus and the perineal body. Obturator internus, or OI, as we'll typically refer to it, comes off of the obturator foramen to the greater trochanter. It is a weak hip extensor, abductor, and external rotator. So when we get into our next phase, which is kind of talking about the impact of gait on the pelvic floor and the reasons why I broke down gait as a pelvic floor physical therapist, it's kind of based on some of those anatomical principles. So our TZ1, we need that hip flexion, adduction, and internal rotation. We're on the next slide in case anybody hasn't flipped forward yet. Because that triplanar short lengthening, so we're not maximally lengthening through those 3 planes of motion, but all of those are in opposition to what the obturator does in concentric phase. All of those motions are creating a vacuum suction on layer 3. We're also going to be having some vertical displacement that occurs. Think about trampoline effect of the pelvic viscera coming down onto layer 3. So a very bouncy gait is going to cause more vertical compression on pelvic floor. Depending on how soft and supple or rigid that layer 3 is, we may have a really hard trampoline with a lot of kind of that grand reaction force, or that may be a lot of extra pressure that is over lengthening those muscles and causing some difficulty with controlling that deceleration of tissues. TZ2, getting into our hip extension and abduction, unloads the obturator and the sagittal and frontal planes. However, that excessive pelvic rotation creates more tension in the transverse plane, and that can be something that can either result in active or passive insufficiency for our obturator. So if we think that if I don't get into that position where I'm lengthening it, I'm not going to get that load to explode. Similarly, if I'm over lengthening and staying in that passive insufficiency, I'm mechanically putting my muscle into a mechanically disadvantaged position and then asking it to function. That's really stinking hard. If we've ever tried to do a bicep curl back here instead of a bicep curl further forward, that same kind of idea. So, impact of orthopedic dysfunction on pelvic floor. Lacking foot and ankle TZ1 mechanics can lead to that poor preload or lack of active insufficiency. Shock attenuation issues can result in increased ground reaction force and vertical displacement of that hard stop of the pelvic viscera. Excessive hip adduction, so if we have somebody who has that Trendelenburg, that hip drop, and excessive internal rotation can over-lengthen our obturator and cause some issues. Similarly, if we're lacking some of that hip motion, we may not have an adequate preload into those tissues to have them function well. Of course, TZ2 mechanics can cause excessive lengthening through our obturator, causing passive insufficiency and resulting in fascial strain, or limitations in hip mobility, also poorly affecting the ability of those muscles to function within the desired range. So goals of the PT interventions. The aim for all of our AFS or applied functional science functional activities is to try and improve the chain reaction biomechanics based on the things that we're seeing with that walking assessment that we may do. Improve pelvic floor length tension relationships, reduce ground reaction force to reduce the visceral impact on layer 3 to help with a top-down control strategy, especially for continence. With this, we're also looking to try and match the endurance aspect of their functional tasks as well as the speed. So if somebody is playing tennis versus pickleball, it may be a really similar motion, but at a much different speed and impact amount. Goals here may also be to use agonists or muscles that function in coordination with the pelvic floor muscles for what we call overflow strengthening. So typically looking at gluteals, abdominals, and calf musculature. We're also also looking to try and use our breathing to improve pelvic floor contraction and reduce our intra-abdominal pressure. So with that one, typically we're going to be looking for an exhale with exertion. As we're looking to use that exhale to create the pelvic floor contraction, thinking about a tension to task idea where I don't want to maximally contract and do a pelvic floor contraction or a Kegel. I may be looking to try and just improve the amount of recruitment that we had coming in. Similarly, I may try and use my breathing mechanics to try and help lengthen. So if we're down into a deep squat, I may ask them to do a diaphragmatic breath or a belly breath to try and create more downwards pressure and relaxation in that sense. Let's go ahead and pause it.